a warm welcome not only to you here in the room, but also to the people online. I'd also very much like to welcome our panel today and our speakers. Today we're going to have the session then on the role of national FETPs, field epidemiology training programs, in strengthening countries' capacities for infectious disease prevention and response. And we're going to get 4 different perspectives, or 4 different country perspectives. The first speaker is Paata from the National CDC of Georgia. And then we'll have online Nada, but yes, hello Nada. I hope you can hear us well.
Hello, good afternoon.
Welcome. Nada from the Ministry of Public Health in Lebanon, and then Nissaf from the Ministry of Health in Tunisia, and Katharina Apers from the Robert Koch Institute in Germany. So, good. Was there any issue or no? No, good. Then I think this is a really interesting discussion that we're going to have, and I think really a necessary one. For us to be able to really reach the goals and targets and the need that we have in country to have the capacity that different countries need, then we need not only the MediPIET program or the EPIET program or the UFM program, but we need countries to take venture into training their own capacity and to cascade the training. And then I think this is a unique discussion that we're going to have in that sense, that we can share some lessons learned and some good practices in how to get this done, because we have good examples from all these from these countries. So before starting, I'd like to offer a question to a question or two actually to you in the Slido. So please get that up there. Yes, good. So please go in here, and you all have different targets, and I don't think we'll go into them now to say it's difficult to get an idea of how many people you would train. But I would like to think that if you have trained the number of people, what we'd like you to estimate here, and that we will see then at the panel discussion, is if you have a target, how much more epidemiologists do you think you would have to train in your country in order to take account for people that leave, or brain drain, basically, it can also be called. So I think that question is clear. So we could go to the next question. So do you think that brain drain is a problem in relation to FETP training in your country? And then you have some different options. Yes, it's a problem. No, it's not a problem. Or no, it's good that some experts leave the country to broaden their experience. They will contribute to the country in due course. So, and then we have a follow-up question to this one. And basically, if you answer yes, and no matter if you answered no, it's fine. You could also answer to this one because you may have a great idea. What would be good ways to counter this problem? So if you experience drain brain, what do you think could be good ways to counter this? So those are the questions that we will then, now you'll have a chance to answer to them, and then we can return to them in the end at the plenary discussion. So by that, I think we can start, and I will leave the floor to Paata for the first presentation.
Thank you. Dear colleagues, dear friends, history of FETP starting in Georgia since 2009. It was with support of USCDC was established South Caucasus Field Epidemiology and Laboratory Training Program. This was 2-year advanced program, and the program was regional, and for Georgia, Armenia, Azerbaijan, in later in 2015, Ukraine was joined program too. Totally more than 125 specialists was trained. Among them, Georgians was 60. Among these 60, 35 was from human health, 12 from veterinary health, 4 lab specialists from human health side, and 9 from laboratory specialists from animal health sides. And then this program was, advanced program was finished in 2017. In 2019 was FETP Alumni Association established. And of course, objectives was to mobilize the FETP alumni to respond to disease outbreaks or other events of public health importance, provide support to host country governments, and strengthen regional cooperation in field epidemiology and response capacity. For example, we use our Armenian colleagues in Armenian-speaking district during some surveys, and our Azerian colleagues during the surveys in the Georgian districts when mostly Azerian-speaking population are lived. Then was established Frontline FETP in 2018. This is 3-month program, consists of class training and fieldwork. Training language was Georgian, just Georgian, because it was trainees was selected mainly from our regional public health centers. 8 graduates from South Caucasus FETP were invited as mentors for the frontline cohorts. And in 2019, Frontline FETP program was transitioned. It was started with cooperation with USCDC and was then transitioned to the NCDC Georgia. And second cohort was trained by our staff, and totally was up to 40 graduates. And Georgia joined to MediPIET since 2015. It was more than 30 external participants involved in different modules. 10 experts became to TAUTs, and 19 abstracts accepted at our annual scientific conferences, among them 2 oral. In 2019, it was 2 graduates from human health sector, and of course, with gained knowledge and experience, facilitated the establishment of public health preparedness and response division at our center, and prepared human resources and acquired knowledge used in response to COVID-19 pandemic within rapid response teams. And the mode of continuation with 2 fellows now, and I think both of them are here. Then in the FETP intermediate was introduced in 2021. It's our same with support of USCDC. This is same regional program, and participants countries now it's Georgia, Azerbaijan, Armenia, plus Moldova and Ukraine. 19 national senior specialists are selected as mentors. Among them, from Georgia, 6 mentors, and already have 2 graduates from human health sector and 2 graduates from animal health sector. Is in the mode of continuation too. And finally, we launch One Health FETP. It's starting from next spring. Program oriented to improving response capacities within One Health scope. This will be a 3-month pilot program, and 17 residents from animal health, human health, environmental sectors, and selected mentors are same field epidemiology laboratory advanced training program graduates. Training language will be Georgian because it's just for Georgian specialists, and it will be piloted in 4 regions. And finally, we use this our cohorts of trained, advanced trained epidemiologists for workforce development and for public health network in Georgia, and this program was launched this year. This is public health course, surveillance of communicable, non-communicable diseases, biostatistics, health promotion, environmental health, which selected 8 mentors, and already trained more than 200 public health specialists in the regional level in our country. This is very briefly what we are doing, and thanks so much.
Thank you very much, Nada, for this. I think we will leave the questions for the panel discussion. So if you have questions now for Nada, please enter them in here into the questions or the chat. If you enter into the chat and you find a question that you like, you can like it, and then you can that will show me a bit on how many think that this is a good question. So I think the chat is interesting in that sense. So by that, thank you very much. I think really fascinating and impressive amount of training going on now in Georgia, and indeed interesting. But let's discuss afterwards. So I think now, Nada, if you're with us, it's time for you then to tell what your experience from Lebanon. And the reason now the speakers are going down is because these monitors don't work, so it's good that you sit down there so you can follow. Good, thank you. Please, Nada.
Thank you very much. Good afternoon, everyone. It's a pleasure for me to present the Lebanese experience regarding national FETP. So I will start with the context of health security, meaning to have activity required to minimize the impact of public health events across countries. But thinking about health security means that we are thinking at global level. But to think global level, we have to act locally at national level. At national level, we have to think about this capacity to early detect, investigate, and respond, and to have the national critical mass of field epidemiologists. When we think about this critical mass of field epidemiologists, we have to think about the ratio of one field epidemiologist per 100,000 inhabitants, but also about this decentralization to cover all provinces and all districts. In Lebanon, we have 8 provinces and 26 districts. So what will be our critical mass, or what is our critical mass for Lebanon? So we have to think also about this basic or frontline FETP with 3 months duration, the intermediate one with the 9 months duration, and the advanced one with 2 years duration. For the basic one, we need to cover all surveillance officers at the MOPH, but also public health officers not in charge directly with the surveillance. But also we need to cover the focal person in health facilities doing the reporting to the MOPH. And here the number is at least 400 fellows to be trained. As for the intermediate FETP, here we need to cover the ones who have succeeded in the basic one, and priority is for the MOPH and related sectors, meaning agriculture, education, and other sectors related to health. And here we need to have at least between 50 to 80 fellows trained. As for the advanced, here we have to cover the MOPH at central level and provincial level, and the number needed is between 25 and 40. But we have the brain drain. In Lebanon, through the MediPIET, we have 5 graduated from MediPIET. Among those 5, 3 left. 60% is our brain drain today. So it's a loss for the country. So we are losing competent staff. And there is no recruitment to replace them currently due to this economic crisis. So every time we have economic crisis in Lebanon, we are having brain drain. But at the global level, it's not a loss, it's a gain, because those people who left Lebanon went to supranational institutions, and it's a gain because they are contributing to the global health security. For we have to think that brain drain is not always a loss. It's a loss for the country, but still a gain for the global health security. As consequences, when we want to measure our critical mass, we have to consider this brain drain for the country level and to increase critical mass during crisis to up to multiplied by 2. And also because we have repetitive crises in our countries, so we have to put a plan, preparedness plan for the crisis. What we do if we have a crisis and we have a large brain drain, so we have to think about it. And one way for that is to prioritize during crisis the basic and intermediate FETP, because you are training more and more people during these fellows FETPs. In Lebanon, we have set the national FETP this year, so we are still in a junior phase. And the trigger to have this national FETP was to build our critical mass. Through MediPIET, we have 1 to 2 posts per year, and this is not enough to reach our critical mass. So we need to initiate our national FETP to have large size of fellows and cohort to be trained. As per our plan, we have 3 phases. Phase 1, the short term, initiating the basic FETP, meaning the 3 months duration. And then we need in the phase 2, the midterm, to initiate, in addition to the basic, the intermediate one with a 9 months duration. And then for the long term, the phase 3 is to initiate our national FETP with advanced curriculum. The FETP in Lebanon is hosted at the ESU Epidemiology Surveillance Program at the MediPIET, which is a MediPIET training site, and the core team of this FETP is from MediPIET national team. As for the training platform, we are using the ANFNet LMS, and the follow-up of this implementation is done with ANFNet. Our first cohort was from Feb to June 2022. We had 1 coordinator, MediPIET graduated, and 6 mentors and 15 fellows. They had to complete 3 modules, blended modules, where we have face-to-face and online, and it was done in Arabic version. Each fellow had to complete 5 projects to complete this FETP. So we have links with other networks. Already, we have the ANFNet link, where we have the ANFNet providing direct support for the implementation of the national FETP, and also providing the library for training material and the learning platform LMS. In addition, we have this network and link with the MediPIET, where we have building the core team for the national FETP, director, coordinator, and mentors. And also we are using the library of training material and case studies. And also from both of them, from ANFNet and MediPIET, we are benefiting from their savoir-faire and their continuous capacity building and networking with other countries and other FETPs. When we talk about FETP, we need to think about quality, because it's not academia. And here, our keyword for FETP is the field and the quality of the training. So in the quality, we have 2 ways to do it, either through review. So what we do in Lebanon, that after each cohort, we do a review. And the review includes the following methods: review of the training material, survey with fellows, survey with mentors, test integrated in modules, and review of portfolio. But also we need to think that we want to be accredited through the FENET accreditation. We are not still eligible yet because we started this year. We have to wait to have at least 2 cohorts of intermediate to be eligible for the accreditation, but we can start to be ready. We can start to work on management and infrastructure, to work on integration with public health service, to work on staffing and supervision, to work on selection and training of fellows and quality improvement. So starting from now will make easy for us to have accreditation in the coming years. Another keyword for FETP, sustainability. We had a workshop this year with ANFNet where we have used this ANFNet GHD sustainability assessment matrix, and 6 components are mentioned. We have to be in an institution, we have to look about partnership, about flexibility, about innovative approach and methods, about evaluation of our work, and how to have competent human resources. So we did this exercise, we did the assessment with a main goal to have a sustainable national FETP covering national and peripheral levels and offering basic, intermediate, and advanced curriculum. And list of activities have been mentioned to be implemented in the coming time. At the end, I want to thank MediPIET family, ANFNet GHD family, and also my team, FETP team, to be with me and to be in Lebanon, still in Lebanon. Thank you very much.
Thank you very much, Nada, for that nice presentation. Again, please post questions for Nada, and if you still have questions for Paata, please continue posting them, and then we will discuss them afterwards. The questions have started to come in. So then I'd like to invite Nissaf to share experience from Tunisia.
Then it's I have to move. Good afternoon. It is my pleasure to present today Tunisia experience. Thank you to MediPIET and SKD organization to give us the floor to present our experience. For us, I will start with the history of field epidemiology in Tunisia. We started in 2004 and 2005 to establish a 3-month training for Tunisia, Algeria, and Morocco. We got only 2 cohorts, and after that, this project was not viable because of the funds, and we already trained 12 participants per cohort. And it was at that time I was a fellow in this program. And after that, the Observatory of New and Emerging Diseases was created. And one of the missions of the observatory is to establish a training in field epidemiology. Then we start our program with a short course of NTO-EP for national and regional level. It was a 3 weeks training, and also we sent some of our fellows to some international FETP programs like the Prophet in France, or we participate to NTO-EP with EP Concept and ECDC, and it was also not sustainable because it depends on funds and it is not enough to reach our critical mass of field epidemiologists. In 2012 and 2013, we start conducting our EpiTune training. It was also a training for our focal point in the 24 governorates of Tunisia. It was at the early warning units, and we start with this activity, but it is not enough also because they have only the basic training to analyze data and to establish some surveillance system. And 2014, the opportunity was here to discuss about what is the priority in our region, and we had the conference, and we discussed that we need a sustainable program for our region, and it was MediPIET born at that time, and we start with MediPIET project, and Tunisia was involved in MediPIET project since that time. And after that, we decided that we need not only the advanced program, because the number of people trained at MediPIET were not enough for our mass capacity in Tunisia, and we did an assessment about what are our needs in terms of field epidemiology, because we already have medical doctors who are specialized in epidemiology, but working especially in research activities and in other activities not in the field. They are at the university, and we established in 2018 our FETP with the institution who is responsible of this FETP is the National Observatory of New and Emerging Disease, and we create a unit and we have a budget for this activity. The aim of Tunisia FETP is to develop a sustainable program in field epidemiology in order to support the continuous learning needs of professionals involved in response to many threats, and also involved in our early warning and response system, and also to strengthen the capacity to respond to public health threats and emergency in the country, and to have this networking of field epidemiologists who are ready to respond to any outbreak or any threat. And the expected results of the Tunisian FETP is the national epidemiology surveillance system is consolidated and sustainable at national, regional, and local level, that the public health emergency are timely detected, investigated, and a response is provided rapidly and effectively, and the professional skills of staff in the field of epidemiology are strengthened and implemented, and also to have epidemiological data of high quality to be able to conduct research activities. Based on the best available evidence, the previous experiences at national need assessment in Tunisia, we launched our program with the 3 levels: the basic or the frontline, the intermediate, and the advanced. And we follow this pyramidal aspects of the implementation of our FETP. For us, the advanced now is run with MediPIET project since 2014, and we already have 5 cohorts involved, and also we benefit from different TOTs and mentorship offered for supervisors. We established the intermediate FETP with the support of AMFNet and the US CDC, and already 4 cohorts of 1-year program since 2017 are run. And recently, we also established our basic FETP, 2 cohorts of 3 months program since 2020 were also established. And here, the most important that we are using the cascade in our FETP. Those who are graduated from MediPIET and previous experiences are the facilitators, the coordinators, and also the mentors of the intermediate. And those from intermediate are also mentors, supervisors for the basic program. What are the success in development EPFORs in Tunisia? It was support to our Ministry of Health, because we only have per year 2 or 3 places offered by the Ministry of Health for new specialists in epidemiology. Then it was the opportunity to have this critical mass of epidemiologists through this program. And for what is the impact of our MediPIET project and others that graduated are in the key Ministry of Health position at the Observatory, the Institute of Public Health, and other direction. Graduating are leading response in crisis situation, and during COVID-19, they were in the front line to respond to the COVID-19 at point of entry, testing, contact tracing, investigation, data collection, everything. And they are supporting decision-making related to COVID-19. They developed and supported development of protocols, guidelines, SOPs. There were rising awareness toward public health issues, conducting research studies, and also conducting a lot of scientific publication. And they are very, very active, and they participated to many national and regional and international conferences. What are the challenges? The health system can only manage emerging and re-emerging crises if having an adequate, well-trained, willing EPFORs. And what Nada said is also true for Tunisia, because now more and more we have this economic crisis, and we are afraid that our youngest epidemiologists will not stay in the country. That's why we need to train more and more people to enhance the capacity at national level. Because for global health security, we cannot talk about global health security without enhancing the capacity at national level. We cannot have talking about security at national level without having this capacity at regional and at local level. That's why we need to maintain this program for a long period of time, training from local to national, and repeating training. Either they want out Tunisia, we will be happy for them if they will enhance their capacity in their career, but we need to train more and more people. That's why we need to maintain the FETP program as the motor of health security at country level, to be able to protect health at a global level. And for us, one of the questions is how to secure funding to support the FETP. We succeed to have budget in Tunisia, but we need more budget to maintain the advanced training to be able to run the intermediate and the basic level. Field epidemiology program have shown that, field epidemiology shown that they are very strong in fighting outbreaks, but we need to support them. We need to maintain this training for the future of the global security health. Thank you.
Thank you very much, Nissaf, for those words and the warm words for FETPs. Again, remember to post questions. We still need some more questions, I think, both for Nissaf and the previous speakers. And then I welcome Katharina up and sharing the experience of Germany.
Thank you. So, let me briefly share the experience we've had in Germany with applied epidemiology training. So, Germany is located quite at the heart of the European continent, and it has actually borders with 9 other countries around. It is a federal republic, meaning that there are 16 federal states that each have their own public health institutes, and the responsibilities for both health and training lies with the federal states. However, the responsibility for infectious disease control lies with the local level, with the around 400 public health departments we have in Germany. So when the infectious disease protection was restructured in the 1990s, amongst the many things implemented there, it was also realized that in order to keep up this new structure, we need to train the people to fill these new structures. And that was the birth of the 2-year national program, and also some short courses that were offered to the broader audience. The postgraduate training in applied epidemiology, as we call our FETP now, from the very beginning has been working together with MediPIET. And in the beginning, all the fellows were trained in the Department for Infectious Disease Epidemiology at Robert Koch Institute. In the year 2006, we started to also send fellows paid by RKI to the federal state level. In the year 2009, we started collaborating with the local Berlin Charité University for a master program in applied epidemiology, which we offered to all our fellows. And recently, we have now managed to also include fellows that are paid and hosted by the regional and also the local levels to take part in the training program. The master was accredited in the year 2014 and reaccredited in 2018. And in February 2020, we received the TEFINET accreditation. The collaboration with MediPIET means that we have the shared training contents and objectives that you can see listed on that slide, but it also means that we contribute to the theory modules organized by the training program. In the beginning, we only had very few fellows, and the program started to increase slowly when we started to send fellows to the federal states. There was a new income in the year 2009 due to pandemic influenza money. And now recently you see the impact of the corona pandemic that has led to the inclusion of the fellows from the federal states. Among the nearly 100 fellows that have graduated our program since the beginning, nearly 38 are exactly 38 are working at Robert Koch Institute, and about 23 at the federal or local levels in the public health services in Germany. There is a certain brain drain to international organizations such as ECDC and WHO, and already we have the first of our fellows that have retired, so that's another thing we also need to think about. Both fellows and alumni have been contributing in the management of all major public health crises we have had during the last years in Germany. And as examples, I want to mention the H1N1 influenza pandemic, the 2011 huge outbreak of hemolytic uremic syndrome that was then detected to be due to fenugreek sprouts. There was a huge hospital outbreak among neonates in 2012. And then we had a big outbreak in 2012, which we thought was one of the biggest outbreak, which was the biggest outbreak until then, with 11,000 cases due to norovirus in strawberries imported from another country. Now, this is nothing to what we have seen in the last 2.5 years, and with many more cases in the SARS-CoV-2 pandemic. And both alumni and fellows were vital in the response to that pandemic. They, amongst other things, they helped to set up and manage the situation rooms, both at national and at state level. They participated in field investigations, which were really important in the beginning, especially of the pandemic, to find out, to learn more about the pathogen, about its incubation, transmission modes, and all these important data we didn't have. And so conducted applied research, and we have now also fellows involved in doing interaction reviews. The main learnings from the crisis was the 3 points. And that has come through all those crises, the importance of communication, and good communication. And in order to have good communication, it really helps to have a good network and to speak the same language and understand what we're talking about. And of course, as I have mentioned, we need evidence, good timely data with high quality in order to base our decision making on. So these are all things the field epidemiology programs are fostering. So definitely the learning has been over all those last years, as the speakers before me have already said as well, we need more field epidemiologists. So how to expand the competencies in intervention epidemiology in our countries? What we have done so far, as you have seen, we have managed to expand the existing 2-year FETP by collaborating more with our federal states. But that's not enough. It never will reach the critical mass of one or two trained field epidemiologists per 100,000 that has been mentioned before. So far, we have only 0.2. So in order to get more of this expertise, we think we also should discuss to introduce new levels such as the intermediate or basic frontline courses. In order to reach our goals, we are sure we need to have the collaboration and networking both within our country with the federal states, but also within the European Union, which is so important for us as we are so at the heart of that continent, but also with the wider international network. We do think, and we're working on that, we have to adapt to the new times, we have to introduce new content, and one of the huge issues we have to address is climate change, both in content, but also in discussions on how to reduce our travel and maybe cover some of the modules by hybrid or online versions. So I hope I have given you some food for thought, and thank you very much for your attention, and I'm looking forward to the discussion.
And we can also then start having the questions from the Slido presented, please. So please join us. So thank you very much for these Very interesting presentations, and I'd like to now see what we have here on the Slido. Now I can see it there, so I'll look at it here instead. So, in order to take into account brain drain from your country, then this is a word cloud. So the biggest numbers are the ones where you have most people answering. So we're seeing quite some significant for 60%, and there's also a small version there. We have the 500%. That's definitely an outlier, but that's also quite impressive in that sense. And then 20 to 30%. So that is really interesting. We could go to the next slide, please. So is this a problem for you or not? And many would say, 50% say no, it's not a problem. It's important that experts leave the country to broaden their experience, and they will contribute in due course. So this is interesting. However, 40% would say that it is a problem, and then 12% say it's not a problem. And then we can go to the next slide, please. This is, let's see if I can have this. So, yes, so what would be good ways to counter this? And we can see agreements with ministry to involve people in projects and further trainings. Listen to or for the brains. Talk with stakeholders. I think that was a nice one. Brain drain cannot be caused by FETP. The FETP bridges gaps between countries and establishes standards. That's really good. More funding, more resources, improve living conditions, wages. Yes, job security, promotion, better career opportunities. Train more epidemiologists. Okay, thank you very much. I think those are really interesting. Would anybody care to comment this or reflect over this?
Maybe for the brain drain, we need to talk about this. By Shoah, there are a lot of serious economic issues in many of our countries. And by Shoah, we need to resolve this problem. It is not related to field epidemiology. It is a general problem. Not only epidemiologists are leaving countries, but also other young people related to this global situation. I think now it becomes more and more a global concern. I think that to resolve this problem, we need to train more and more. Either they left, it is maybe a good opportunity for them, but we need to secure our countries at different levels to be able to respond in a rapid way and to protect health, as I mentioned. For me, we need, it is not a kind of how many per population, it is a continuous training to be able to respond in a proper way. That's why we need to maintain these different initiatives. These different programs are very helpful for all of our countries, and here it is a call to maintain funds for such program for health security. It is very, very important.
Thank you, Nissaf. Anyone else who wants to comment on the findings?
Yeah, by my view, it's absolutely, I don't see any problems with brain drain because if they are, it was third one, yeah, I think they then can contribute more to countries when they are living somewhere and working in international organizations, for example, why I don't see the problem that this is, it's very important to choose the right person to send to the somewhere to study. Mostly if it is from already people who are working in our institution, because people who are coming there, they know this is not a very huge salary there and something like this. They are enthusiastic people who like to be working on like epidemiologists. And why, if you are choose right people to send somewhere, the majority of them are back. If someone are left, it's are very good too.
Thank you for that, Paata. I think several of the questions here in a way relate to this. So one of the questions being how do you ensure sustainability and if people don't leave the country? And the other question that kind of relates to it as well is how do you work with building career paths for fellows in the country? So before, I just wanted to introduce that as a question for you to respond to. How do you work with establishing career paths for fellows in your country? And you can comment on that and as well as on the Slido questions if you wish. I think Katharina, you're wanting.
So for the brain drain, I think one important element is also to create working conditions that are attractive to the alumni of our program. So it's not only the salary, but it's also the kind of work, the working atmosphere. So that's one thing we can do. And I think another issue how to get people as working at the places where we need them to work is actually train the people, as you said, that are already working there. And that's why we have decided to really increase our program in a way to include people that are already working at the local or at the regional level, because they're less likely to then afterwards want to go to ECDC.
Yeah. So yeah, this is about the career progression then, I guess. As well. Nada, would you care to comment as well, or?
Yes, I would like to add that brain drain is a problem when we cannot replace the people, when there is no recruitment to fill the vacant post. For example, I have lost more than 20 staff during these 2 years with no replacement of these posts, and this is a problem for me. And as Nissaf said, FETP, it's a continuous training. It's not one cohort or two cohorts or three cohorts. We have to sustain FETP, whatever was the level, basic, intermediate, or advanced, because we will find that more people have to be trained in our country. We can go to the health educators, we can go to municipalities, local authorities, and to train them about epidemiology so they can be more prepared when we have new pandemics. Over.
Thank you for that, Nada. So there are also questions that pertain to the different levels, and I think that may be interesting. What is really in the levels of a front line in your models, and what is in the level of the intermediate, and also because that also answers to that there may be very different needs of in the country to fulfill. So how would you relate to this?
In Tunisia, we have conducted need assessment at different levels to see what are the domains that we need to cover for each level. And for the local level, the main important thing, how to do a report from surveillance system, how to evaluate their system, and also how to conduct outbreak investigation at local level. It is the basic knowledge about this basic field epidemiology competencies at local level. And we identified the topics with the field, and we implement these 3 modules covering surveillance, outbreak investigation, and evaluation. And we have 2 field activities related to either establishment of a new system, evaluation of one system, or conducting outbreak investigation. It's for us the priority for the local level. For the intermediate, it is 9 months, and it covers those who are working at the regional level, at the direction of healthcare centers, and they are in charge of surveillance. And we covered here more domains, and also it's based on a need assessment, and we covered all the basic modules, and we have more case studies. For example, we add foodborne disease, we have vector-borne disease, we had we have a lot of activities that are coming from what are the main health problem in Tunisia related to infectious disease, and we focus on how to establish a surveillance system, how to investigate an outbreak, and how to evaluate a system. It's around this, but they have 5 field work to conduct in different domains. They must cover all these domains, and they have a portfolio, both of them, to present. And for the advanced, you know that it is more it is with MediPIET, and it is aligned with EPIET. And we are in process also to revise the curriculum. Maybe for the curricula in Tunisia, we decided to include also One Health approach for our intermediate program, because we, for our response team, rapid response team, usually we have a multi-sectorial team, and we decided to involve them, and it was a very successful experience. That's why for our FETP in Tunisia, either for the advanced, if we will plan to implement the advanced FETP, because we need also critical mass to be able to implement our 2 years program, it was decided to be One Health FETP, covering not only animal health, human health, but also people working at lab level. And here we have experience with Robert Koch Institute with the EpiLab training. And during COVID-19, it was shown that we need epidemiologists, but also we need lab to know how epidemiologists are thinking to enhance our system. That's why we decided to have lab, EP, and animal health in our future FETP.
Thank you very much, Nissaf. So just to a question there for you, the countries who have now a basic or frontline and intermediate and advanced, what would you call the people? Are they still called trained epidemiologists at all these levels, or what would be the title? Maybe Nada or Paata could answer. What's the definition of a trained epidemiologist?
Yeah, difficult question. Even for advanced trained. But yeah, still it's for trained. They are trained epidemiologists, yeah.
Yeah, trained field epidemiologist, yes.
Here we have a concern. In Tunisia, to be epidemiologist is a specialization in medicine. It is a national exam, and it is a specialization offered only for medical doctor. So then that's why when we established field epidemiology, now we have field epidemiologists who are different from specialists in preventive medicine and epidemiology.
Okay, thank you.
Now, in my country it's different, because even now we have previously during the Soviet tradition, it was just medical doctors was epidemiologists, but now we have even bachelor's degree in it's in medical university, but we have bachelor's degree on public health.
Yes.
And then they can after to finish, and this is no more medical profession.
That's right. Yeah. So I think those are quite important questions and distinctions. So I'd like to, before we finish off, because it's just 1 or 2 minutes left, I think many countries here, or people from countries where we don't have front lines or intermediate or advanced programs, and even in Germany, it would be really interesting to hear what do you think is the real important trigger to start a program, a frontline or an intermediate, or what's really needed? What's the important facilitating factor? Maybe Nada, you could start, and be quite brief, because we only have 1 or 2 minutes.
Okay, so you need, I think, 3 points. You need the willingness, because there is need to build our critical mass. And you need to have the people, the core team, the coordinator and the mentors to be there. So you need to have the need to train more people, and you need to have the adequate team, competent team to do this implementation. Over.
very much, Nada. You want to complement Paata or Nissaf?
We need more monitors and supervisors that are available for the fellowship, and it is one of the concern to have these mentors and supervisors, and also to give them, when they are in the mentorship, to give them the time, because in sometimes they are nominated to participate and they are not allowed to conduct their activities, and this is one of the concern in our countries.
Thank you very much for that. So to summarize a bit now where we're at with this discussion, I want to thank you really much, because it's been really 4 different perspectives, and so interesting to hear from you. Basically, I think that we've identified some really critical things that are needed. You would need the team and the support and the political will to do this. And then you got to adapt your program for your needs, and look into that, and basically define at the different levels that and not least which group you are aiming to train. It seems like that is also something that has broadened within your countries from the start. And I think this is really also, it seems like the brain drain was a discussion that was really nice in the sense that it may be a problem or it may not be, as long as we have enough people coming into the system. That is something that we're willing to take. But of course, then that's an issue of resources. So I'm really happy to hear this strong support for the FETPs at various levels, and I do hope that we can continue working together to make this happen even to a larger extent. So thank you very much, Paata, Nissaf, Nada, and Katharina, for sharing with us today and for your great views. And thank you, everyone in the audience, for contributing so much. So.